Over to Dr. Bharat Shah. Welcome, sir.
Thank you, Dr. Fatak. So, after that wonderful talk by Dr. Devi Shetty, let's come to the problem that we see very commonly in our clinical practice. And while the topic is newer approaches to management of CKD and hypertension, I'm going to confine myself more to talk about hypertension in chronic kidney disease because chronic kidney disease management is a big subject by itself. And there are not many new things in management of CKD and hypertension. Therefore, my talk will be about management of hypertension in chronic kidney disease. So what I plan to do is tell you about association between chronic kidney disease and hypertension. I will then talk about management of hypertension in patients with chronic kidney disease, and then I'll tell you briefly about the newer approaches in management. What is the association between chronic kidney disease and hypertension? We all know that hypertension is common and it affects about 30% of the general adult population, but it affects 90% of those with chronic kidney disease. So it's almost synonymous with chronic kidney disease. It can be a cause of chronic kidney disease, but more often it is a complication of chronic kidney disease and an important factor contributing to the progression of chronic kidney disease. In practice, I do not see many cases where hypertension was the first thing to start and then over a period of time they went on to develop chronic kidney disease. What I find in clinical practice more often is that they present to me with chronic kidney disease and they have with it hypertension as a complication. As kidney function declines, the incidence and severity of hypertension increases. Additionally, hypertension and chronic kidney disease are both independent risk factors for cardiovascular disease. Lowering blood pressure can slow the decline in kidney function, delay the progression to end-stage kidney disease, and reduce the incidence of cardiovascular disease. Let me give you an example to show what a great role kidney has to play in causing hypertension. So this was a 32-year-old female with end-stage kidney disease on maintenance hemodialysis. She was very well dialyzed 4 times a week. And you know that in patients with end-stage kidney disease, volume is an important component in causing hypertension. So she was being dialyzed 4 times a week. Her target dry weight was maintained, and she was on no medication that would raise her blood pressure. And still her blood pressure used to remain 170 by 100 millimeters of mercury. And see the medication that she was on. She was on an angiotensin receptor blocker, she was on ACE inhibitor, she was on loop diuretic, she was on a calcium channel blocker, beta blocker, centrally acting alpha agonist, she was on prazosin, and she was on minoxidil. And despite that, her blood pressure used to remain 170 by 100. She underwent a living-related donor kidney transplant. Mother was the donor. This was in 2015. She had excellent renal function. And within 3 months of transplant, her blood pressure was 120 by 80 on metoprolol 25 milligram once a day. And even today, with good kidney function, she maintains such excellent blood pressure control. Well, the other side of the story is also true that hypertension can be a cause in development of end-stage kidney disease, and it correlates with the severity of hypertension. Greater the hypertension, the greater the risk of developing end-stage kidney disease. But I would once more like to reiterate that hypertension as a cause of chronic kidney disease is much less. In my practice, it is much less. It is by and large chronic kidney disease which is a cause of hypertension. And therefore, I tell everyone that any patient presenting with hypertension must be evaluated for kidney disease. We now go to the next part of my talk, management of hypertension in chronic kidney disease. So what remains true of hypertension in general remains true of patients with chronic kidney disease also. So lifestyle changes are extremely important even in management of hypertension in chronic kidney disease. Weight control, if one is overweight or obese, you all know that 40% of our patients with chronic kidney disease are diabetic, by and large type 2 diabetic, overweight and obese. And weight control will help not only the diabetes but also the blood pressure control. We all know about the important role of salt restriction in management of hypertension in general, but that is even more important. This is even more important in patients with kidney disease who tend to retain salt and have a state of volume overload. Exercise remains important for all. Reduce consumption of caffeine-rich products, reduce intake of alcohol, and extremely important is to stop smoking. Smoking not only increases the cardiovascular risk, but also increases the renal risk. And if these factors, if the lifestyle change fails to achieve a control in blood pressure, then obviously one should resort to pharmacotherapy, because a good control of blood pressure has an important role in retarding the progression of chronic kidney disease. So when it comes to pharmacotherapy, there are three important factors that we need to take into consideration. One is an accurate measurement of blood pressure. The other is the choice of a number of drugs that we have available to us for control of blood pressure and achieving a goal blood pressure. How does one accurately measure the blood pressure? By and large, I don't think it is practical to go by what the books say, that you make the patient sit down in a silent room for 5 minutes, have 2 readings. I don't think most of the centers in the world are practicing what is suggested to us. In most cases, the treatment of hypertension is based on clinic or office blood pressure reading, which is not enough. It is like managing blood sugar on the basis of one reading you have in 1 month, 2 months, or 3 months. That's not correct. The most important is monitoring the blood pressure during the day. 24-hour ambulatory blood pressure monitoring provides a more accurate depiction of blood pressure. It also allows assessment of diurnal variation in blood pressure. But frequent ambulatory blood pressure monitoring is not practical. How frequently can you put someone on ABPM? It's not possible. Home blood pressure monitoring is an alternative strategy, and it is less resource intensive and much more practical. Today you get digital blood pressure instrument for 1,500 or 2,000 rupees. It is not difficult to monitor the blood pressure 3 times or 4 times in a day. You come to know about the diurnal variation in blood pressure, and that can help you adjust your blood pressure medicines. So home blood pressure monitoring is very practical and should be applied, particularly in cases where blood pressure is difficult to manage. Now let me come to choice of drugs. Since we are talking about hypertension in patients with chronic kidney disease, we should be looking at drugs which not only control the blood pressure, but which would slow down the rate at which the kidney function declines. And what happens in patients with chronic kidney disease? There are adaptive changes that take place in the surviving nephrons. Now let me tell you what I mean by adaptive changes. If in your office there are 10 people working and 5 people leave the job, the remaining 5 people have to work hard to make sure that the work gets done. In the same way, let us say 75% of the kidney is permanently damaged. Now 25% nephrons are remaining. They will work more. If your normal glomerular filtration rate is 100 ml per minute, if 75% of kidney is damaged, your glomerular filtration rate will not be 25 ml per minute. It will be 50 ml per minute. Because each surviving nephron works more. And how does that happen? At the efferent arteriolar level, there is a vasodilatation. So there is more glomerular blood flow. While at efferent arteriolar level, there is vasoconstriction. So this combination of increased glomerular blood flow efferent arteriolar vasoconstriction increases the glomerular capillary pressure, and each nephron increases the filtration. There is an increase in single nephron glomerular filtration rate. And this is the fact which maintains the glomerular filtration rate higher despite subsequent reduction in the number of surviving nephrons. Having understood this, we should use drugs that reduce blood pressure as well as glomerular hypertension. Because what may be sounding good in the beginning, glomerular hyperfiltration, is itself responsible for progressive decline in kidney function over a period of time. Besides the underlying cause of kidney disease, these adaptive changes themselves are responsible. So if in your office there are 10 people, now 5 people are working, but if they continue to work very hard for long, they themselves may fall sick. Something similar happens over here. So you want to reduce the workload on the kidney, and you want to reduce the glomerular hyperfiltration. And this is what can be achieved by ACE inhibitors and angiotensin receptor blockers, which will reduce the efferent arteriolar vasoconstriction and reduce the glomerular capillary pressure. So your first choice should be use of an ACE inhibitor or an angiotensin receptor blocker. If these drugs are not tolerated, then your next choice will be calcium channel blockers, particularly those which block not only the L-type calcium channels, which is the first calcium channel blocker which came nifedipine and amlodipine, but N and T calcium channel blockers like cilnidipine and vanidipine offer an advantage of reducing the glomerular capillary pressure. So, as far as CKD and hypertension is concerned, as I said, your first choice will be ACE inhibitors and angiotensin receptor blockers. This would be even more important in cases where you have proteinuria. When your urine protein to creatinine ratio is more than 1, it's very cumbersome to ask someone to do 24-hour urine protein all the time. So in practice, in a spot urine sample, estimating protein and creatinine is good enough. If your urine protein to creatinine ratio is more than 1, then again, use of ACE inhibitors and angiotensin receptor blockers is preferred. If your urine protein to creatinine ratio is less than 1, then you may use calcium channel blockers or other antihypertensive agents. When you introduce ACE inhibitors or angiotensin receptor blockers, monitor creatinine and potassium and ask them to repeat within a week of introducing. If there is more than 25% rise in creatinine, then you would want to stop it. But if it is less than that, you might want to observe, and I'll explain to you at the later part of my talk. If proteinuria is less, creatinine is stable, but potassium is a problem, continue these drugs and use loop diuretic. They will not only help in reducing the volume overload, but they'll also take care of hyperkalemia. And in my experience, chronic kidney disease subjects tolerate higher potassium up to 6 milliequivalents per liter much better, because it is not the extracellular potassium concentration, it is a ratio of intracellular to extracellular potassium which makes an impact on the heart. And since the total body potassium is increased in CKD, it is fine if the potassium is little higher in patients with chronic kidney disease. So choice of drugs. The first step would be ACE inhibitor or angiotensin receptor blocker. If not tolerated, a calcium channel blocker. If the blood pressure is not controlled, you will use ACE inhibitors or angiotensin receptor or calcium channel blocker and add a diuretic. Diuretic is an important part in control of blood pressure in CKD subjects. If the blood pressure is still not well controlled, ACE inhibitor or angiotensin receptor blocker, calcium channel blocker plus a diuretic. And if it is still not controlled, then you will add an alpha blocker or a beta blocker. One important point to remember, and that's true for all cases of hypertension, is adjust the timing of medication in such a way that you can achieve an improvement in nocturnal dipping of blood pressure. It has been found that nocturnal dipping of blood pressure, which is a normal diurnal phenomena, is lost in patients with chronic kidney disease, and that becomes an additional factor increasing the risk of cardiovascular disease. The aim should be to achieve a blood pressure of 130 to 140, systolic by 80 to 90. In those with proteinuria kidney disease, a slightly lower blood pressure is desirable. And in elderly men, don't go for an aggressive blood pressure control. Go for a blood pressure of 140 by 90. But there is no consensus. Appropriate blood pressure target for patients with chronic kidney disease remains a subject of debate. Overall, individualized blood pressure target should be set only after weighing potential risk and benefits of blood pressure control. If one is not comfortable with a very rigid control, one should allow, because after all, it's important to have a good quality of life, and you don't want a postural fall and patient having a fall in the bathroom. Now we come to the newer approaches. There are not many newer approaches. Of course, one newer approach is to use the digital technology. We had a wonderful talk from Dr. Devi Shetty for achieving a good blood pressure control. I use this. I ask my patients to maintain and send me the readings. It's very useful in adjusting your medicines. But all of us are recently reading more and more and hearing more and more about sodium glucose co-transporter 2 inhibitors. These drugs have proved to be a great asset in management of patients with type 2 diabetes, diabetes with kidney disease, diabetes with cardiovascular disease, and these drugs have proved to be useful even in lowering the blood pressure. How do they lower? The SGLT2 inhibitors, while they cause glucose diuresis, while we lose glucose, they also induce osmotic diuresis and natriuresis. So your volume part is managed, which is important, as I said, in chronic kidney disease. And another thing, what we saw with ACE inhibitors and angiotensin receptor blockers, a similar thing happens, that by a tubuloglomerular feedback mechanism, the afferent arteriole, which is vasodilated in patients with diabetes and chronic kidney disease, by giving SGLT2 inhibitors and providing more delivery of sodium to the distal tubule, you achieve a narrowing of the afferent arteriole, you reduce glomerular blood flow and glomerular capillary pressure, and that helps in retarding the progression of chronic kidney disease, while at the same time you achieve an improvement in blood pressure control. There was a recent article this month itself about dapagliflozin in patients with chronic kidney disease. And before this, there was an article about canagliflozin, but that was restricted to patients with diabetes and chronic kidney disease, whereas this study included 4,304 participants with estimated glomerular filtration rate of 25 to 75 ml per minute and with proteinuria, who were put on dapagliflozin 10 milligram once a day. But the most important part of the study is that they included not only diabetics with chronic kidney disease, but 1/3 of the subjects were non-diabetic chronic kidney disease. And they found a significant beneficial effect, not only in achieving a blood pressure control, but in retarding the progression of chronic kidney disease, improving the renal outcomes and improving the cardiovascular outcomes. So this is what happens. When you give a drug like SGLT2 inhibitor or an ACE inhibitor, or when you restrict dietary protein in patients with chronic kidney disease, there will be an initial rapid drop in glomerular filtration rate. And why does this happen? Because I explained to you that there is an afferent arterial constriction, reduction in glomerular capillary pressure, reduced filtration. But this reduced glomerular capillary pressure and hyperfiltration, which causes an initial rapid reduction in GFR, is very beneficial in the long run.
Dr. Bharat Shah?
I have 1 minute.
Yeah.
So if you have a constant rate of decline in kidney function, otherwise with SGLT2 inhibitor, you have a slowing down of the rate of decline in kidney function. And the same thing was observed. There was a 30% reduction in deaths from cardiovascular causes or from any other cause. So let me summarize. While hypertension can be a cause of chronic kidney disease, more often it is a complication of CKD and an important factor contributing to progression of chronic kidney disease. In management of chronic kidney disease and hypertension, lifestyle changes are as important. Home monitoring is very important. The first choice of drug is ACE inhibitor or angiotensin receptor blocker because they not only reduce blood pressure, but they reduce glomerular hypertension and they reduce proteinuria, an important prognostic marker in chronic kidney disease. And SGLT2 inhibitors are a new class of drugs to be considered in management of chronic kidney disease with hypertension. I would like to thank the organizers for giving me this opportunity, and I would be happy to answer the questions at the end of the session.